Good morning, everyone, respected sir, my seniors, and my colleagues. Today I'm going to present management of rectal adenocarcinoma with synchronous multifocal high-grade dysplastic polyps. Is the case discussion and future planning of that case. Starting with the case, a 58 years male presented to us from Tanau, who is a known case of benign prostatic hyperplasia and under medication. He had a past surgical history of right immunohormonoplasty and has no known family history of carcinoma or cancer. He presented with a PR bleeding, peritoneal bleeding for 2 months, red in color, which was not mixed with stew, painless. He had no other history of like constipation, diarrhea, or fever. On examination, his ECOG was 0. He was fair looking, no pallor, no teres, no lymphadenopathy. For abdominal examination, it was soft, non-tender. There was no obvious mass felt. But on coronary examination, polypoidal mass, which was formed in nature, was felt about 7 to 8 centimeter above the anal walls. And this is the initial colonoscopy report, which was done in another center. We showed the finding of mid-ascending colon sessile polyp approx 12 mm, semi-pedunculated polyp approx 10 mm, 10 centimeter from anal walls, and which was about size 15 to 40 mm. And in this center, they took the biopsy from only the rectal polyp. And after that, the patient underwent CCT abdomen and pelvis with rectal contrast, which showed enhancing pedunculated soft tissue lesion. They mentioned that it was in a sigmoid colon, which was of about 33 into 26 into 15 mm size, with partial luminous stenosis and no extraserosal extension, pedicle fat stranding, or the local regional lymphadenopathy, suggestive of maybe neoplastic lesion. And this is the CT finding of the rectal contrast, which shows the polypoidal mass in the CCT. And patient also underwent MRI pelvis, which showed the similar lesion in the sigmoid colon, and it mentioned with the luminous stenosis, which mentioned the stage as T2, N0, M0. And this is the mass with the evident polypoidal mass evident in the MRI report. And from the rectal mass, which the biopsy was taken, the histopathology report came out to be well-differentiated adenocarcinoma. And after this, all the investigation, the patient was referred to our center, where we again performed colonoscopy. And full-length colonoscopy was done, and which showed the similar rectal mass, that is polypoidal mass, of about 3 to 3 centimeter for 7 centimeter from anal burst. And apart from the ascending colon sessile polyp, there was evident another 2 polyps, one in descending colon 10 mm size, solitary sessile polyp, and transverse colon 5 mm solitary sessile polyp. And during this same setting, polypectomy of the 3 polyps were done from descending colon, transverse colon, and ascending colon. And the size are mentioned respectively. And the histopathology report came from these polyps from the descending colon, which was 10 mm size, the adenomatous polyp, adenoma with high-grade dysplasia with no cancer invasion was seen, and transverse colon 5 mm size, it was only inflammatory polyp, and ascending colon, which was size about 20 mm, adenomatous polyp with high-grade dysplasia. In this also there was negative for invasion, and the rectum previous biopsy 40 mm adenocarcinoma was seen. And after the polypectomy of the 3 evident polyp, we then performed the lower anterior section with ileostomy 10 days earlier for the rectal mass, and his post-operative period was uneventful, and his final histopathology report is awaited, and we plan to send for the IFC after the final histopathology report. And without delay, I will not be mentioning all the features of colorectal polyps and all. I would jump to the treatment procedure and correlate to this case, and was the treatment for this particular case correct to our right or not, or it was correct to our guideline or not. And I will refer to the recent NCCN guideline. In the recent NCCN guideline for the rectal carcinoma, as in our case the early stage carcinoma with N0 disease, it recommends the first line treatment of transabdominal resection LAR with TME as a standard procedure, and for the smaller lesion less than 3 centimeter and which are very small and specific non-ulcerated T1 N0 lesion, they suggest they recommend the transanal local excision. And for the colorectal polyps, as per the similar guideline, the first line treatment they mention as complete endoscopic resection. Preferred techniques are snare polypectomy, endoscopic mucosal resection, or endoscopic submucosal dissection, as per the pedunculated or sessile lesion or the size of the lesion. And the complete endoscopic dissection is termed as adequate when it meets the criteria of complete excision with clear margin, no invasive carcinoma, and there is no lymphovascular invasion. And for this, in which cases we do not go for the complete endoscopic dissection, but prefer the surgery are for like incomplete, in case where the incomplete endoscopic dissection is done, or there is positive after the endoscopic dissection, positive or indeterminate margin are seen, and if there is any suspicious or evidence of the invasion carcinoma, and unfavorable histologic features like submucosal invasion or poor differentiation or lymphovascular invasion are seen. And endoscopically, the lesions which are not endoscopically resectable, and there are multiple synchronous advanced adenomas which may raise the concern of hereditary syndrome, like more than 10 polyps or above. And for this, the surgery is the oncologic colectomy with lymphadenectomy. And in our case, there was a complete excision and there was no invasion of carcinoma in these cases. So we can say that the complete excision or the adequate resection has been done. For our case justification, it was a mid-rectal carcinoma for which the standard of treatment lower anti-resection with TME was favorable, and even the low differentiated tumor was favorable, and we did the sphincter preservation surgery, and synchronous polyp which was endoscopically resected was also no invasion of carcinoma and clear margins were seen. And why we did not go for extensive surgery. Also, this is supported by NCCN guideline, and total colectomy or proctocolectomy was not indicated in our cases because there were only few polyps, that was less than 10 polyp, and out of 3 polyps, there were only 2 adenomatous polyp. One was only inflammatory polyp, and there was also the polyp where there was no evidence of the invasion of the carcinoma, and the patient was more than 50 years, and also there was no significant known family history of any carcinoma, either endometrial or any colorectal carcinoma in the past. And soliciting did this total colectomy or proctocolectomy may be the overtreatment and can increase the morbidity in this patient. And for the what do the NCCN guidelines support for the total colectomy or proctocolectomy? If there is sporadic rectal carcinoma, segmental resection, like in our case, and in case of the advanced adenomas, complete endoscopic excision can be done. And in case of, even if the case is of the hereditary syndrome, which are suspected, molecular test is suggested, but not the empiric colectomy. And role of chemotherapy. Usually in the colorectal carcinoma, the indication are in the stage 3 colon cancer, high risk stage 2 cancer, like in the poorly differentiated endocarcinoma, locally advanced rectal carcinoma, and usually with chemotherapy, the radiation therapy are also given. There are various trials which suggest the use of both chemo radiation therapy for the neoadjuvant treatment. And in case of the adjuvant chemo indication, after the final histopathology report, if there is no positive disease and if high-risk features like lymphovascular invasion, peritoneal invasion, and closed margin, and also the poor differentiation type of the tumor, and the common regimen we that use are Folfox, Capox, and in the where the patient are cannot due to the toxicity tolerate the Folfox or Capox, 5-fluorouracil and even capecitabine tablets can be used. And role of radiotherapy. This is primarily in the rectal carcinoma, where the disease are T3 or T4 tumors. There is no positive disease, and there is threatened CRM. And usually the approaches are long course, either radio chemotherapy, as earlier mentioned, with combination with chemotherapy, or only the short course radiation can be given. And the total neoadjuvant therapy, in cases where the wait and watch procedure, wait and watch technique or the surveillance is used. And the main goal are for the downstaging and the sphincter preservation, the radiotherapy, and the local control of the disease. And the role of immunotherapy. Till now, it is indicated in MSI high cases or detected MMR gene in colorectal cancer. And the commonly used agent are pembrolizumab, nivolumab, either plus minus ipilimumab, and this is also suggested or the advanced by the NICE guideline. And for the evidence, there is high response rate in the metastatic MSI at colorectal carcinoma, and also there is emerging organ preservation trials where for the localized rectal carcinoma can we only use the immunotherapy with chemotherapy and defer for the surgery. Can not go for the surgery, only give the immuno or the chemotherapy. And this one trial, recent review article, which was published in 2024 in Frontier Journal, which mentioned the types of immunotherapy as immune checkpoint inhibitors, adaptive cell therapy, tumor-infiltrating lymphocyte, or oncolytic virus therapy. But till now, only immune checkpoint inhibitors like pembrolizumab are currently the standard of care. And even in this recent NCCN guideline, universal MMR testing are mandatory, and for the DMMR and MSIH rectal carcinoma, immune therapy has been used as the upfront treatment. And in a few articles similar to our case, which has seen the synchronous neoplasm with synchronous adenomatous polyps, and this is a trial which was published in recent 2025, single center retrospective colonoscopy study, which was done in 1900 cases. We showed the colorectal carcinoma was prevalence in about 4% cases, and the predominant location were rectum and the sigmoid, and the synchronous polyp were present in about 47.4 colorectal patients, and adenomas like cases were constituted in 60% of synchronous polyp, and 38% of the synchronous lesion were in the usually in the same colonic segment, either left or right, and it was higher prevalence in the male cases and in the older patient with a mean age of 65 years. And for the clinical significance, nearly 1 or in 2 colorectal carcinoma harbors the synchronous adenomas, and colorectal carcinoma frequently represent a field disease, not only a solitary region. And the complete colonoscopy is always mandatory in suspected case of polyps, and this suggests that even as segmental oncologic resection with endoscopic clearance can be done in these synchronous lesions. And there's also a similar article which was done in 678 patients. It was retrospective pathology tumor. It was related with the WHO classification. It also shows similar findings of 96% epithelial polyps. Tubular adenoma were most common, about 70%, and among them 1.4% were advanced adenoma, high-grade dysplastic polyp, and there was synchronous adenocarcinoma in about 1%, and there was strong association with the retrosigmoid lesion and male predominance. Conventional adenomas, they carry a higher risk of synchronous neoplasia, and even small adenomas like less than 10 mm can be biologically relevant, as they confirm the low but real risk of synchronous carcinoma and support the colonic clearance plus surveillance, but not prophylactic colectomy. And so, since there is the presence of 4 polyps, 3 and the 1 rectal carcinoma, can this be a hereditary colorectal carcinoma? For this case, our main 2 consideration would be attenuated familial adenomatous polyposis and the Lynch syndrome. So, moving on, which can be this case, since we are awaiting for the final histopath and the IHC report. In this case, since the patient has only less than 10 polyps, the diagnostic features of attenuated familial adenomatous polyposis are at least 10 to 100 adenomatous polyps, younger age less than 50, right-sided predominance is seen, and APC gene mutation is seen. And since in our patient there are only 2 adenoma cases, age is also not included, as it is more than 58 years, and there is no significant family history, so it is less likely, and can we consider the Lynch syndrome, since even there are many articles which show that even in absence of the family history, Lynch syndrome can be present, as in this case also there is colorectal carcinoma with synchronous advanced adenocarcinoma, and there is one adenoma in the ascending colon which was more than or equal to 20 mm with high-grade dysplasia, and there is also the family history, and family history is not present. So in that, even in cases of family history not present, Lynch syndrome, like MMR gene mutation, has been evident in many cases. Thus, in this case, the Lynch syndrome cannot be excluded clinically on. And to rule out Lynch syndrome, we do the universal tumor testing. First, the somatic testing. We can send from the rectal tissue biopsy from our final histopath, the MMR ISC, to look for MLH1, MSH2, MSH6, and PMS2. Or if not possible, we can do the MSI testing, and we can interpret the result as if the MMR is intact and the microsatellite is stable, then the case can be of sporadic colorectal carcinoma. But if there is MMR loss and MSI instability is high, then we can suspect the patient has Lynch syndrome. And in case of the MLH1 loss, to further categorize it as either sporadic or the Lynch likely, we can see for the PRAF mutation and also the MLH1 promoter inhibitors. And after doing this, if this somatic testing, if it comes back abnormal, then we can go for the germline testing to confirm if the mutation is present in every cell of the patient body. That is, either it is hereditary or just the tumor has the Lynch syndrome. And for the familial adverse polyposis testing, though less likely in this case, what if in future he develops in the surveillance, if he develops more than 10 colonic polyps, then this test may be essential. For this, the DNA testing with APC gene sequencing can be done, primarily gene for the FAP and the attenuated FAP. And another is the MAP, MUTHY associated polyposis. We can also do if there is presence of more than 10 polyps in the future. And for the surveillance, how and with what tools we can do. If only it was in the case of the advanced adenocarcinoma, then the NCCN guideline and the many other guidelines says that the colonoscopy can be done at the 3 years interval. But in our case, there is the presence of rectal carcinoma and also the advanced adenocarcinoma. Thus, the surveillance needs to be done in prior, at least yearly, as is suggested for the rectal carcinoma. And for the rectal carcinoma surveillance after the curative treatment for stage 1 to 3 disease, with no distinct mets, the clinical surveillance can be done with history and physical examination and digital rectal examination for every 3 to 6 months for 2 years, then for every 6 months through next 5 years. And CA in the blood can be seen for every 3 to 6 months for 5 years, especially in the stage 2 and 3 cancer, to see for the recurrence. And for the imaging, CNCT chest, abdomen, pelvis, to see for the distinct mets and the recurrence every 6 to 12 months up to 5 years is done. And for the endoscopic surveillance, that is via the colonoscopy, at 1 year after the surgery, and if this is clear, then we can opt for the every 3 yearly Then after that, if that is also clear, then we can do every 5 yearly. Like in our case, if there is advanced carcinoma with colorectal, advanced adenoma with colorectal carcinoma, like in our case, then the shorter interval, like 6 months, may also be considered and may require longer than 5 years surveillance period. And the rectal imaging in the selected cases, MRI, where we have opted for the non-operative wait and watch period, MRI and the proctoscopy may need in every 3 to 4 months for the first 2 months, then evaluated in every 5 years. This is also one recent brief article. This is for the adenoma, advanced adenoma. There are various guidelines, all listed here, which shows that the adenoma which are more than or equal to 10 mm with villous tubulovillous feature or a high-grade dysplasia, like in case, if only there is adenoma present and high-grade dysplasia, then 3 yearly colonoscopy surveillance can be enough. And for enhanced surveillance in the Lynch, if confirmed by our histochemistry when the final SP report comes out, then colonoscopy every 1 to 2 years may be required. And also with that, we should consider for the upper GI gastric surveillance, upper GI endoscopy in 3 to 5 years, and extracolonic screening, like in female for the endometrial carcinoma. And if the So genetic testing also comes out positive. Then genetic counseling and cascade testing for the first generation relatives can be done to rule out the hereditary disease. And for the since there is a risk of metachronous lesion, synchronous adenocarcinoma with colorectal carcinoma increases the risk of new lesion. Thus, the longer surveillance and careful follow-up may be recommended. And the emerging biomarker and the future direction. ctDNA liquid biopsy is recently also mentioned in the NCCN guideline that it may be helpful to detect the minimal residual disease and is a potential marker for the recurrence. And in the lead surveillance, the new coming emerging are the AI or the chromoendoscopy enhancement to detect the smaller adenomas. And from this, my take-home message is while the synchronous adenoma may occur in the sporadic colorectal cancer, they present especially when advanced adenoma are seen, may warrant the evaluation for mismatch repair deficiency and for the Lynch syndrome. Always the complete colonoscopy evaluation is necessary in all colorectal patients and colorectal carcinoma patients, and segmental surgery is adequate in sporadic colorectal carcinoma, and prophylactic colectomy is not justified without the genetic indication. And MSI and MMR status drives modern colorectal carcinoma management, and immunotherapy is the standard of care in case of MSIH carcinoma and DMMR, which redefining the colorectal carcinoma treatment. And SCN 2025 supports the personalized biology-driven care, including the immunotherapy and the organ preserving strategies. But mainly the management decisions should be multidisciplinary, always integrating the pathology, surgery, oncology, and radiation oncology and the genetics, and also the patient-driven. These are my references. Thank you.
Thank you, Dr. Sachi. The question ko thaune dekhiye. Everything has been elaborated so detailedly, so I didn't find any question. Very so much about the Lynch syndrome. We are not quite sure. He doesn't give any hereditary or family history of malignancy, colorectal malignancy, or endometrioid, or ovarian malignancy, or pancreatic malignancy in the family. He says that he's the only one who is suffering from the cancer so far. It means there could be a probability. He said very clearly one of the slides. It doesn't mean that he is not suffering from Lynch syndrome. Maybe he is the first person from where the Lynch syndrome is getting to be started. And in the next subsequent generation that will be followed. My question will be, in this particular scenario, is it mandatory to look for the Lynch syndrome?
So, yes, because patient is 52 years old and the lesion up to T3, there is always need for the universal testing of MSI and the MMR genes in colorectal cancer, especially in case of T3 lesion and in case of metastatic disease. So, in this case, we need to do, and we also prescribe patient to do for this test. So, this will guide us for one of the immunotherapy and to go for further testing or not.
Please send not only for HPE but also for MSI and DMMI, right? This is the first one. Colorectal cancer. You are never sure. You are never sure whether he is really the first person from the Lynch syndrome hereditary malignancy is going to be started or not. You are never sure. And the family history is fine. And maybe usko family history sign. So you suggest person maybe he is the first person.
Whether to treat or not, you case treat garni ki nagari huncha. MSI MMR le pani.
Your part now she was talking about second part regarding the necessity of NGS. What do you mention? What do you would like to comment on that?
Actually, it is very costly to send germline testing and somatic testing in our context, sir. What I do
is separately.
Yes, sir. It is very costly. Although the guidelines suggest to go for both germline and somatic testing, sir. Our population could not afford for it. So what I do in my practice is there I go for the somatic mutation analysis. If there are few factors or few things that will tell us whether it is germline or somatic. That will give us hint, sir. One of the factor is variant allele factor. Let's say if I found APCG mutation, then if the variant allele factor is more than 50, sir, then I will suggest it as a
genetic
as a
autosomal
dominant. If variant alpha factor is less than 50, then I will get it as a somatic mutation analysis. And this is quite good helpful in our context. And what we do here, although it is not recommended, but it will give us the answer. And there are few things like EPCAM, MLS1, MSS2, PMS6, and others, and SKT11 for Peutz-Jeghers syndrome. These genes will also help us.
So it means you are trying to say that I think personally that definitely we have to keep in mind that patient has got the hereditary probability or not.
Yes.
That will open up the idea that this patient also should be kept under surveillance for other malignancies. He has got the colorectal, but he might develop next point maybe endometrial, ovarian, pancreatic, prostatic, etc. But instead of that, in spite of that, we have to screen the family members also. That's a very good point, and we have to recommend for that. So this is the second point. Now coming to our patient, they will say, NGS we can advise, but out of the NGS we can take this message only, because we have very less targetable exam for the colorectal cancer. Am I right?
Yes.
दुनियाँ गराएर पनि के चाहिँ टार्गेट एजेन्ट दिन सकिन्छ त नि आई डोन्ट थिङ्क सो फार है एटलिस्ट त स्क्रिन अरू फ्यामिली मेम्बरलाई चाहिन्छ चाहिँदैन हि हेज टु बी फलोड अप फर डिफ्रेन्ट क्यान्सर that message can be obtained. Now particular to this patient, so the patient came to our unit. The patient's son is himself is a doctor, and his uncle, patient's uncle, is a chief surgeon, general surgeon, right? So another question comes here. Then we discussed with the family members, all of us, we decided, we said two options. One option is that we don't know what's the entity. Either you go for the total proctocolectomy, you have to bear all the negative morbidity, etc. Maybe you will need to carry the ileostomy for some times, then we can revert it back, or we just do the colonoscopic polypectomy and keep under surveillance. We do repeat the colonoscopy after a certain period, depending upon the biopsy report, and do the major surgery for the rectal cancer. Because the biopsy was not sent from each polyp, and we're quite unsure, even if we take the biopsy, what will be the result? So then they said, no, we do the polypectomy first. So we went for the polypectomy. All the three polyps were removed. The ascending colonic polyp, which was 20 millimeter in size, showed adenomatous polyp with high-grade dysplasia. Transverse colonic polyp was inflammatory only. The descending colonic polyp, which was 11-12 millimeter, was also adenomatous polyp with high-grade dysplasia. So again, we sat and discussed with the family members. So what next? Would you like to go for the research? Because there are different parts of the colon at one point. Maybe it's in the right colon, we could have done right colectomy, etc. But ascending, descending, transfer different points. So if we do the southern, we have to do the different colectomy. So we said maybe it's reasonable to keep on follow-up. So we can do a later time, again recolonoscopy, not waiting for 6 months, maybe after the surgery is finished, and 3 months of period to see a status. We don't know about the margin status because we did the smear polypectomy. The pathologists have not mentioned about the margin. They mentioned there is no invasive carcinoma. They mentioned it. Definitely there is no lymphovascular invasion, there is no perineural invasion. So these are the good prognostic factors, I would say. Just only they mentioned not about the margin status. Because we did the question. So it will be reasonable to follow up after 3 months and to see what's happening with that points. If there is some polyps again regrowth or some residual, we can do the EMR endoscopic mucosal resection. Okay. So that's what we chose with the. What do you think? Is it reasonable?
I think it's reasonable, sir. And sir, have you gone for the germline testing in this case?
Not yet. We have advised, so we will send now. So I think as per your decision, so we'll send for the germline mutation testing, where in the mind, and also for the somatic from this one,
yes,
the tumor itself. So that will be done. So far, I think we have not done bad. It was T2L0. There was no benefit from pre-operative neoadjuvant treatment. We did the sphincter preservation with a good resection margins. So we assume there should be intraoperatively, this will be the R0 resection all over, proximal, distal, radial margins. So this is also from the surgical perspective. Now the third thing that I'm also not very quite confusing for us. In 2022, it was published that dostarlimab alone, no surgery, no chemotherapy, no radiation therapy, MSI high, gave the 90% or 95% complete clinical response in 6 months of time. It was published in 2022, I guess. So now I don't know what's the updated version of this. It means only immunotherapy can cure in certain patients with MSI high. So now my question comes, if somebody comes with the MSI high, if you do pre-treatment, if it's come high, why do we prescribe the chemotherapy again?
Because patient could not afford for the immunotherapy.
No, in the Western area, you go to the NCCN, what they say, if MSI high or DMM are there, still they go for the local advance, they go for the neoadjuvant chemoradiation.
Yes.
Along with the immunotherapy. Why you cannot avoid the chemotherapy then?
So patient could not afford for the.
Yeah. Westerns, you go to the NCCN guideline.
MSI means they have a very good response to immunotherapy, sir. I think that's why they have incorporated.
So why chemotherapy then? The question gastric cancer, diffuse gastric cancer, MSI positive, they will not respond to the chemotherapy. Right? Yes. So it's better out of fraud regime we are giving all of right and left. Patients are not responding. Maybe they have got the GMMR, maybe they have a MSI, that's why they are not responding. Therefore, now the consensus is that it's better not to give them the chemotherapy rather than advice for the immunotherapy. So why not in the rectal cancer? I'm not talking about Nepal, I'm talking about the advanced countries. Look at the NCCN guideline. They say again for locally advanced, start with the neoadjuvant chemoradiation or total neoadjuvant chemoradiation along with the immunotherapy. Why we cannot avoid totally the chemotherapy? The question is only give the immunotherapy and maybe radiation therapy and followed by surgery.
I think so.
Updated ideas.
They are doing overlapping, so I overlap गरेर अनि पछिको रिसर्चहरुबाट आउँदै गएपछि अब 2022 भनिन्छ अलिकति
2022 मा आइसकेको थियो more than 95% complete clinical response के only immunotherapy 12 वटा भए पनि complete clinical response is quite good achievement है अनि टोटली सब चीज अभोइड गर्न त्यो मलाई अब पढ्नु पर्ला बायोलोजीले गर्दा नि MSI हाई हैन MSI हाई भनेको छ मैले सबैमा MSI हाई ओन्ली सेलेक्ट इन्क्लुजन क्राइटेरिया वाज MSI हाई
अनि ट्युमरमै पनि जुन नेक्स्ट जेनेरेसन सेलहरु ट्युमरबाट आउँछ त्यसमा एडेड म्युटेसन हुँदा कतिले चाहिँ अब MSI हाई सँग रेस्पोन्ड नगर्ने खालको पपुलेसन ट्युमर पपुलेसन पनि आउँछ यो भन्दा
100% MSI हाई भयो भने 100% इम्युनोथेरापी त उस गर्दै हुन्छ
उसमा त 12 वटा मध्ये मलाई चाहिँ 11 वटा रेस्पोन्ड गरेर कति गएको थियो के
अन्डर ट्रिटमेन्ट हुने दर्जनको एडेड किमोथेरापी
maybe they don't have enough evidence to support only immunotherapy.
Maybe
That's why cover गर्नको लागि केमो त स्ट्यान्डर्ड रेजिमेन्ट भयो स्ट्यान्डर्ड केयरलाई चाहिँ स्किप गर्नु
जस्तो कि स्टोमा क्यान्सरमा अब एटिनो क्यान्सर डिजमा दे स्टार्ट नाउ रिसेन्टली दे स्टार्ट विथ यो के अरे के ट्रायल भन्छ त्यसलाई म्याटरहोर्न ट्रायल दे स्टार्ट विथ द फ्लोर फोर एलोङ विथ इम्युनोथेरापी
किमोको ब्याकबोनमा इम्युनोथेरापी चाहिँ एकदम कमन छ सर थोरै किमो चाहिँ हाल्नै पर्छ भन्छ जस्तो हामीले सिंगल एजेन्ट इम्युनोथेरापीले मात्र मेबी ड्यू टु ट्युमर हेटेरोजेनिसिटी होला सर ट्युमर हेटेरोजेनिसिटीको कारणले गर्दा नि होला केही गरी इम्युनोथेरापी मात्र भएन भने यताबाट नि आओस् भनेर त्यो चाहिँ मैले नि हेर्नुपर्छ सर त्यसको
त्यो एक्चुअली हेरौँ हामीलाई पनि आइडिया हुन्छ वाइ किन कुनै आइडिया छ कि जसमा चाहिँ एमएसआई हाई छ अथवा इम्युनोथेरापी सेन्सिटिभ चिज छ भने किन केमोथेरापी दिने टोटली एभोइड गर्न सकिन्छ कि छैन होइन त्यो भने एउटा केमोथेरापी खर्च गर्ने चिज बरु इम्युनोथेरापी हाल्न मिल्छ कि हाम्रो कन्टेक्स्टमा पनि त्यसमा पनि खर्च लाग्छ नि केमोथेरापी त्यो स्किप गरेको त्यो पैसा खनिदिने यसमा इम्युनोथेरापी
लङ्समा जस्तो सर पिडिएल1 मोर देन 50% आएर सिंगल एजेन्ट इम्युनोथेरापी छ त्यसमा सायद स्टडी पनि नभयो नि होला
त्यो पनि होला केही छ अरू इनपुटहरू केही गर्नु सर तिमीले त केही सोध्दैन यार कम्प्युटर चलाएको बसिरहेको के हो
बरु एउटा केस डिस्कसन छ सर
थ्याङ्क यू होइन जस राम्रै डिस्कसन भयो राम्रै आइडियाको लागि सचिलाई पनि थ्याङ्क यू धेरै राम्रो प्रेजेन्ट गरेको